This is Surgery Now, brought to you by School for Surgeons. School for Surgeons is the online learning resource of the Royal College of Surgeons in Ireland.
Hello and welcome to Surgery Now. I'm Cathal Kelly, CEO of the Royal College of Surgeons in Ireland, and I'm delighted to launch this podcast which will help surgeons around the world to keep up to date with the very latest in the world of surgery. Since 1784, this college has been dedicated to enhancing surgical education and training. At the present time, there are nearly 4,500 fellows of this college working in almost every part of the world. Surgery Now will reach out to our fellows and indeed to all surgeons around the world to help them to fulfil the requirements for continuing professional development. We hope that these podcasts will create a worldwide community of surgeons based on shared learning experiences. Our podcasts are designed to be downloaded to smartphones or other mobile devices so that they can be watched at leisure or even whilst doing something else. This is Surgery Now.
Hello and welcome to Surgery Now. In each podcast, Surgery Now will bring you the very latest from the world of surgery. You'll have an opportunity to participate in virtual grand rounds and test your knowledge and judgment. We will also bring you expert feedback on cases presented in grand rounds. We will feature the latest developments in surgical technology and also the latest publications in surgical literature. And of course, we will feature the latest news from surgeons around the world. All this and much more in Surgery Now. We begin with virtual grand rounds, presented this week by Professor Oscar Traynor. Later in the podcast, we will have feedback from two consultant experts.
This week's case involves a 42-year-old male who presented to the emergency department with an 18-hour history of acute abdominal pain. The pain started in the central abdomen and gradually shifted towards the right iliac fossa. It was associated with anorexia and nausea, but no vomiting. There were no bowel or urinary symptoms. He had no previous history of similar problems, and in fact there was no relevant past medical or surgical history. He was not on any medications. He works as a school teacher and his general health is good. On examination, he appeared mildly flushed and had a low-grade pyrexia of 37.8 degrees centigrade. Pulse rate was 108 per minute. Examination of the abdomen revealed that he was quite tender in the right iliac fossa with some guarding and some rebound tenderness. There was also crossed tenderness or Rovsing sign. Laboratory investigations revealed a leukocytosis of 13,000. Liver biochemical tests and serum amylase were all normal. A CT scan of the abdomen revealed evidence of acute appendicitis, with the tip of the appendix measuring 2 centimeters in diameter. There was extensive fat stranding in the adjacent viscera, and there were numerous ileocolic lymph nodes, but these were considered not significant. On the basis of the clinical features, laboratory investigations, and imaging appearances, a diagnosis of acute appendicitis was made, and a decision was made to proceed with laparoscopic appendicectomy. At operation, the appendix was indeed inflamed, and the remainder of the laparoscopy was normal. A standard laparoscopic appendicectomy was performed, and double endoloops were applied to the residual appendix base. The appendix itself was removed in a retrieval bag. The post-operative recovery was uneventful, and the patient was discharged home after 48 hours. So far, a straightforward case of acute appendicitis. However, when the histology result came back 4 days later, it confirmed that there was in fact a carcinoid tumour of the appendix. The tumour was 1 centimetre in diameter and was located near the tip of the appendix. On microscopy, this was a well-differentiated carcinoid tumour which was involving the mucosa, the submucosa, and the muscularis propria of the appendix, although the peritoneal covering was not involved. There was no evidence of signet ring morphology or mucin production. There was no lymphovascular invasion, and the local lymph nodes were clear. The margins of the appendix were also clear. The Ki-67 proliferative index was less than 2%. The issues raised by this case, and which you might like to consider, include the following. Firstly, what is the role of imaging in acute abdominal pain? Secondly, what features of carcinoid tumours of the appendix indicate a poor prognosis? Thirdly, what are the indications for further surgical intervention in cases of previously unsuspected carcinoid tumours of the appendix? And finally, in patients who do not require further surgery, what follow-up is appropriate? If you wish to discuss these points, you may enter the chat room on www.schoolforsurgeons.com.
For more than 225 years, the Royal College of Surgeons has been supporting surgical standards and surgical training in Ireland. We have the largest undergraduate medical school in Ireland, along with the schools of pharmacy, physiotherapy, sports and exercise medicine, and nursing. RCSI runs medical schools in Malaysia and Bahrain and is involved in surgical training programs in Africa. RCSI is a global healthcare training organisation. Next, we focus on the latest from the world of medical device technologies. RCSI SIST, the RCSI's innovation hub, works with clinicians and industry, including the following two companies we are looking at today, Aerosurgical and the National Digital Research Centre.
Aerosurgical is a new company spun out of Aerogen, which is a successful medical device company in Galway. And we were spun out to take a special technology to look at treating the peritoneal cavity during laparoscopic surgery for a variety of different indications. We're first looking at pain and the idea of targeting postoperative pain to be able to reduce that by treating the pain before it occurs through the nebulization or aerosolization of a local anesthetic into the peritoneal cavity immediately prior to, and in some cases at the end of a laparoscopic procedure. In addition, as far as we are looking at using this technology, is to apply it to other areas in surgery, including at the very thorny problem of adhesions. Aerosurgical's technology is based on a platform of a very sophisticated aerosolizing tool, which was created actually for dispersal of different medicaments into the lung for a variety of indications. And the technology really is a piezo, a very tiny piezo. If you think of the pin on the head of a pen with 1,000 holes vibrating at 100,000 times a second. So as the droplet hits the top of that pen, it takes and converts through energy passively into a wide dispersing aerosol that is 3 to 5 microns in size, these droplets that are able to penetrate deeply into the lung. And we have now taken that technology and have applied it to the peritoneal cavity because the idea is very clear that there are a variety of things that could be done surgically, and the issue is, particularly laparoscopically, how do you get it to the insides? How do you get into the abdomen with different therapeutics? And one elegant way to do that is through an aerosol. So if you think about how you treat different parts of the human body, the best thing you can do is go to the source. If you want to deal with a lung infection, it's best to be able to go directly through the lung rather than through an IV drip. If you're dealing with metastasis and tumors within the peritoneal cavity, or the possibility of adhesions, or trying to deal with issues of postoperative pain, the best thing you can do is target that site specifically. And of course, when you have laparoscopic surgery, where there's either one port or multi-ports, you have a limited window to be able to access the insides. And if you can imagine an insert into the trocar, being able to deliver this aerosol neatly and evenly across the insides, that's the potential for being able to treat the cavity.
Haystack is a collaboration between NDRC, Cork University Hospital and Metaphor Limited. Cork University Hospital provide us with leading clinicians respected within Europe and globally in the area of peripheral nerve block. The story behind Haystack is a simple one. If you or I break our wrist, we go to theatre, have it repaired under general anaesthetic. We wake up feeling groggy and we have to spend a night or two in hospital. There's a better way. Using regional anaesthesia, We can scan the arm using ultrasound, knock the arm out, carry out the procedure while awake, listening to music or watching a movie. We then won't feel groggy afterwards and potentially go home that night. Why can't every procedure be done like this? There's a lack of expertise on a broad scale in anaesthesia to deliver a peripheral nerve block service. Haystack provides a simple solution. It's a training and assessment tool that allows peripheral nerve block to be trained to the best standards globally accepted, to instill expertise in trainees and clinicians who have already trained. How do we do it? We simply capture the best in-class method for this technology in computer software using what's called a hierarchical task analysis, where we capture each specific procedure move in detail. We then render that in computer software and enable a trainee to use a haptic equipment to get force feedback on the way in which the procedure is done. So they sit at our trainer, they put on 3D immersive goggles, they lift up an ultrasound device and a needle device that enable you to interact with the computer software to give you feedback on how you're doing, show you the errors that you've made, and help you become competent in the area. In effect, Haystack allows you to work with peripheral nerve block, train with it the right way every day. So where's the future for Haystack? We're currently forming a new company looking for investment, and we're fulfilling orders in Q3 of this year. HeartPhone is a collaboration between NDRC, Bianca Med, Crofton Cardiac Systems and UCD. Rapid weight gain for a patient with congestive heart failure can be caused by fluid retention, which is an indicator of heart failure. Current monitoring systems allow a patient to take home a paper and pen, record their weight every day, revisit it with their clinician on a daily, weekly or monthly basis to look at the historical set of weights over time. HeartPhone digitizes this. It uses a smart weighing scales that you stand on every day, that the weight transfers up through a mobile phone to the clinicians that they monitor in real time every day. However, behind HeartPhone is a patent-pending algorithm that monitors the parameters of your weight over time to illustrate and point out to the clinicians if there's any problems that need to be addressed. HeartPhone has been shown to reduce non-necessary hospital admissions and gives the patient a sense of security. The future for HeartPhone is that we're looking for FDA approval by Q4 of this year, with sales to follow.
Ireland is a great place to do business. Now we look at the latest publications in surgical literature in Surgery Now Journal Watch.
The first article that we would like to highlight is entitled Mental Practice Enhances Surgical Technical Skills, a randomised control study. This article is from the Annals of Surgery.
Mental practice is the cognitive rehearsal of a task in the absence of overt physical movement. Studies in the field of elite sport and music have demonstrated that it does optimise psychomotor performance.
Surgical training is looking toward alternative training strategies that are based outside of the operating room. Mental practice could have a role here. The aim of this randomised control trial was to investigate whether mental practice enhances performance in laparoscopic surgery.
20 novice surgical trainees performed a series of simulated laparoscopic cholecystectomies, and the quality of their performance was measured.
The results found that the mental practice trainees had quality measures that were significantly superior to the control group. This study demonstrates that mental practice may enhance simulation training and may reduce the learning curve.
The second article is a 5-year follow-up of the Medical Research Council classic trial of laparoscopically assisted versus open surgery for colorectal cancer, and this is in the British Journal of Surgery.
classic trial assessed the safety and efficacy of laparoscopically assisted surgery in comparison with open surgery for colon and rectal cancer. This paper reports the 5-year follow-up results from the multi-centre randomised classic trial.
It demonstrates that there was no significant difference in 5-year overall survival rates, disease-free survival, and local and distal recurrences between those patients who had a laparoscopically assisted resection and those that had an open resection for both colon and rectal cancer.
However, the authors report that even following adjustment for risk factors, those patients that required a conversion from laparoscopic to open surgery did significantly worse in terms of overall survival.
The results of this study should allay concerns regarding the overall oncological efficacy of laparoscopic colorectal cancer surgery. The use of laparoscopic surgery to maximise short-term outcomes does not compromise the long-term oncological results.
Our third article is entitled Pre-Hospital Intravenous Fluid Administration is Associated with Higher Mortality in Trauma Patients, a National Trauma Data Bank Analysis. This article is from Annals of Surgery. Pre-hospital intravenous fluid resuscitation is intended to hemodynamically stabilise trauma patients by replacing intravascular volume and maintaining vital organ perfusion.
There is evidence to suggest that intravenous fluid administration in the pre-hospital setting does not improve survival in trauma patients and may even be of harm. The objective of this retrospective study was to determine the influence of pre-hospital intravenous fluid administration on patient outcome.
The results demonstrated patients receiving pre-hospital intravenous fluids had a significantly higher mortality rate.
In particular, patients with a penetrating injury, hypotension, traumatic head injury, and patients that required immediate surgery had a higher mortality risk.
This paper concludes that the routine use of pre-hospital intravenous fluids in trauma patients should be discouraged. Other articles to look out for include Stress Management Training for Surgeons, a randomised controlled intervention study. Out-of-hospital hypertonic resuscitation after traumatic hypovolemic shock, a randomised placebo-controlled trial. Single incision laparoscopic surgery for right hemicolectomy. Effect of the circumferential resection margin on survival following rectal cancer surgery.
Surgery Now, learning while you are doing something else. Next, we have Spotlight on Surgery, where we look at the work of surgeons around the world. This week, we hear from 2 orthopaedic surgeons from Ireland and their work in Haiti following the devastating earthquake of 2010.
We went out to Haiti about 10 days after the earthquake itself. While we were there, we met Dr. Louise Ivers, who's an Irish graduate who helps run medical services for a charity called Partners in Health, who are based in Boston, and she brought us to visit one of their hospitals, which was outside the earthquake zone, but because it was still standing, was involved in treating a lot of the patients who'd been injured in the earthquake itself.
There was 3 orthopaedic surgeons who travelled out, and we spent about 4 days there, and we set up arrangements whereby more expeditions could go out and continue to work throughout the year.
I suppose the biggest challenge for us in that specific environment was the number of cases and the complexity of cases. There was a huge number of people with catastrophic limb injuries caused by crushing with falling debris. As well as the volume of patients, the existing infrastructure in Haiti was very limited, and the ability to source the kind of equipment that we would use in treating fractures here was really non-existent.
That was one of the biggest challenges. We're very comfortable looking after a lot of these injuries when we have our image intensifier, when we have all our x-ray equipment, when we have good pre-operative x-rays, when we have very good sterile equipment, none of which we really had over there. So we were treating these injuries with what was available to us, which was for the most part, external fixators or frames, which we use to stabilise fractures. Most of the injuries were limb injuries, and there were a lot of open injuries and a lot of wounds that needed to be treated. A lot of what needed to be done was what we call debridement, where we just clean out the dead tissue and take away infected tissue. And in some cases there were some amputations still to be done at that stage, and try and stabilise the fractures that we could.
So it was very much back to first principles for us, and using a certain amount of intuition and using some of the knowledge that had been passed to us that we hadn't necessarily used before. One of the challenges for us probably was knowing what was good enough. Sometimes some of the techniques we used and some of the levels of fixation were not what we would necessarily accept here, but given things like the sepsis rates that we were fearful of and the significant complications, it was sometimes safer to accept something that may, on the face of it, look to be inferior, but in fact was going to give the patient a better outcome. One of the cases that we saw while we were there was of a lady who had a very significant crush injury about her elbow, with fractures and with some soft tissue loss, including muscle and skin. We were faced with a very difficult situation with a patient where we really had an unreconstructable limb in the setting that we found there. And we had to make a decision about whether or not this patient would be best treated with an amputation. So for us, there was a very psychological, difficult decision to make, to sacrifice a functioning hand for want of techniques and instruments that would often be available here. Added to the fact that there's a big cultural issue in Haiti about limb loss, which may change in coming times, it really was a difficult decision for the patient and for us to make, and really, I suppose, highlighted in very stark fashion the difference in the practice in that environment, in that setting, with those type of injuries over what we would see here.
The other issue was that we were only there for a short period of time, and we didn't really know who was going to be looking after the patients after we left. So that we had to be cognizant of this fact, that we could come in and do something that might be sophisticated but would also require sophisticated aftercare, and that might not be available for the weeks following this when we had left. There have been a series of subsequent missions or trips out to Haiti over the last year, and one of the important things that has been emphasised is to integrate the care that's provided by the Irish health care workers with the local workers. It has been a very rewarding experience, I think, on both sides, in that the Irish people have really enjoyed working with the Haitian staff, who are very committed, very dedicated and very skilled, particularly in the context of what facilities and what training they have.
Well, to date, the whole process of our involvement in Haiti has evolved. As John said, we were there very early, in the very early days, and faced with such a huge number of injuries and faced with limited resources, we're very much involved in triage and urgent care. We've sent about 80 Irish healthcare workers, doctors, nurses, physiotherapists, logistics people to help in all different facets of it. And the type of people that we've sent and the type of work they've done have changed significantly over that time. And what we're very keen on doing is trying to get involved in teaching. The teaching hospital was significantly damaged. The university was destroyed. So the residency program, the training program in orthopaedics, effectively ceased in one day. What we're hoping to do is to try and help them set up a new residency program, to try and teach local Haitian doctors, to give them the ability to learn locally with the resources that are available to them, to help us identify resources that can be maximally used, to give them some access to the expertise that's available in the West, and hopefully to build a lasting legacy rather than just get in and do some care and treat a number of patients.
On a personal level, I mean, I'm very glad to be involved in it. It was a terrible, terrible thing that happened to that country and to those people. And when you go over there and you see them just stoically going about things and getting over it and continuing to look after themselves and look after each other, it is a very impressive thing to experience.
What you're faced with over there, the depth of misery, the diminished resources that people have, are quite disturbing, really. And I think maybe that's one of the reasons why this project has maintained momentum. Most people I've spoken to have felt that they've gained more than they've given, and that it's only by trying to maintain it and keep it going forward that they can repay some of what they've gained in terms of the humility that you learn by facing these things.
School for Surgeons is the online learning support centre for Surgery Now. Visit our website to see how School for Surgeons can provide support to you. And now we have some expert feedback on the issues raised in virtual grand rounds from Dr. Eric Heffernan, consultant radiologist, and Dr. Dermot O'Toole, consultant gastroenterologist, as they discuss some aspects of the case.
Even in the setting of typical symptoms and signs of acute appendicitis, as in this case, imaging can play an important role in helping to exclude alternative pathology and also in helping reduce the negative appendicectomy rate. When trying to choose an imaging test to perform in the setting of acute right iliac fossa pain, it's always worthwhile considering whether or not you can get the answer without using ionizing radiation. While it might be tempting to go straight to CT, ultrasound is often the best first test. Particularly true in the case of female patients of reproductive age, in which case not only are you reducing the level of radiation that they receive, but ultrasound also is far more sensitive than CT at picking up gynecological pathology, which would be high in the differential diagnosis list in that patient cohort. Ultrasound is superior to CT in identifying things like hemorrhagic ovarian cysts, ovarian torsion, tubo-ovarian abscess, and so on. A downside of ultrasound is that it is very operator dependent, which may be an issue in on-call situations. It also has a number of limitations in obese patients, with it being very difficult to obtain good quality imaging. It does, however, have a very high specificity and positive predictive value for acute appendicitis, both of which are greater than 90%, but it is hindered by a low sensitivity and negative predictive value in the order of 60 to 70%, which means that a negative ultrasound test has to be interpreted with some caution. But it is a very good test for ruling in acute appendicitis. CT has a similar specificity and positive predictive value to ultrasound for acute appendicitis, but has the added benefit of a very high sensitivity and also negative predictive value, both of which approach 100%. It's also superior to ultrasound for alternative non-gynecological causes of right iliac fossa pain. It has the advantage of being fast, it's not operator dependent, and there is no significant image degradation as a result of patients being obese. There is, however, a significant radiation dose in the order of the equivalent of 400 to 600 chest x-rays, which is definitely an important consideration in these usually young patients. MRI in acute right iliac fossa pain is generally limited to pregnant patients, but in that cohort it does play a very important role as a safe alternative to CT in the situation where distortion of the normal anatomy by the gravid uterus makes interpretation of ultrasound very difficult or often impossible.
This young gentleman demonstrates classical features of carcinoids of the appendix and has very reassuring overall parameters. That is, a tumour less than 1 centimetre with favourable histology, well-differentiated profile, a low Ki-67 proliferative index, and no lymph node involvement. The international recommendations here are for no follow-up for tumours that are less than 1 centimetre with favourable histology and no lymph node involvement, obviously. So no further therapy and no follow-up is required, and the patient can be perfectly reassured. What are the features then that we look for in terms of deciding whether further therapy is warranted? It is clear from the international literature that tumours greater than 2 centimetres require further therapy with right hemicolectomy, and for tumours that are between 1 to 2 centimetres with unfavourable profiles such as deep mesoappendix involvement that is greater than 3 millimetres, or for tumours with proliferative index or other poor histopathological features such as slightly higher Ki-67, then this will be discussed on a case-by-case basis at a multidisciplinary expert panel discussion. However, most experts feel that tumours between 1 and 2 centimetres without unfavourable histological parameters can be dealt with without further surgery, and follow-up is not indeed warranted. The unfavourable histopathological parameters involved in decision-making include any mucoid or goblet cell differentiation or involvement of deep involvement of the mesoappendix that is greater than 3 millimetres, or obviously any involvement of extra appendiceal organs. So for tumours that are less than 1 centimetre and that have complete or zero resection, no further therapy and no follow-up is warranted. For tumours that are between 1 to 2 centimetres, the majority of these tumours do not require further therapy or indeed follow-up, provided that the margins are indeed clear with no unfavourable histopathological parameters.
And finally this week we have Image of the Week. Our Image of the Week this week comes from a 45-year-old female patient who has had an incidental finding during an ultrasound performed for non-specific abdominal pain. This is her ultrasound scanned, and there is an abnormality in the gallbladder as shown by the arrow. She went on to have a CT scan which confirmed the abnormality as indicated by the arrow. What is the nature of this abnormality in the gallbladder wall? What is the significance of this finding? What, if any, treatment should be undertaken? Submit your feedback to the School for Surgeons website. That's all for this podcast. Starting soon, we will have regular Surgery Now podcasts, which will be available to surgeons around the world and which will help you to keep up to date with the very latest from the world of surgery. Thank you for watching.